Okay, we start recording. Thank you so much for being today in our review for pharmacology. Okay, so this review, the intention of this review is to go over important topics that you must have as a base for pharmacology. And we are going to start from, we are going to review the all lectures, and we are going to highlight what is important, and I really want you to please pay attention and take notes and repeat it as many times you can. That is important. All right, so let's start. So we are going to talk about, first of all, about pharmacokinetics and pharmacodynamics. So for this, I want just you to remember that what is pharmacokinetics definition, very clear, right? So, and what is the pharmacodynamics definition? I want that very clear. And you can tell that the pharmacokinetics is what we call the ADME, right? So the absorption, the distribution, the metabolism, and excretion. Open eyes, open ears, please. So for example, when you have liver disease, what could be of the ADME steps, what could be the problem, or what is the organ who is going to be involved? So if you, the metabolism basically is by the liver, Now, question, what organ involve the excretion? So remember ADME, okay, absorption, distribution, metabolism, and excretion. So that is the kidney, right? Kidney, because remember the functions of the kidney, fresh, right? One of those is the excretion. And if you have the kidney failure, and mostly the drug is going to be eliminated by the kidney, obviously it's contraindicated. Obviously, too, if you have a drug that is mostly metabolized by the liver and you have liver failure, that is going to be contraindicated too. Okay? All right, so that is about the pharmacokinetics and the pharmacodynamics. For this, I would like you to just remark about this. Drug metabolism. Drug metabolism, we already talked, that is affected by the liver functions, right? Drug metabolism. Drug metabolism. Another thing I want you to remember is the half-life time. Half-life time. So take note about that. Half-lifetime. What is half-lifetime? Is the time where 50%, listen, 50% is eliminated by the body. 50% eliminated by the body. Half-life time. Okay? So if, for example, you have 100 milligrams right now and you have half-life time 4 hours, okay? So that means if you take it at 6 o'clock in the morning, at 10 o'clock, these 100 milligrams at the beginning become 50 milligrams in your body. Why? Because the other 50% are being eliminated, right? 50% of the medication is eliminated or excreted by the body. If you have 60 milligrams and the half-life time is 4 hours, 60 milligrams at the beginning, 4 hours, 4-hour half-life time. So that means that you start at 8 o'clock, at 12 o'clock will be 30 milligrams. So 50% will be eliminated. Okay, so that is about, so let's continue. Let me see. Okay, another thing that you must know is the concept of first pass effect. First pass effect. First pass effect. But what is the first pass effect? Is everything, any medication who is being in contact with the gastric acid, for example, right? Gastric acid. So first pass effect, that means that the acid, part of the medication will be destroyed and only part of that will be absorbed. And the first pass effect doesn't end here. It's going to continue when they are reaching the liver. The liver is going to metabolize part of this drug, and only a percentage of this is going to be into the bloodstream to make effect in the target organ. So again, so the first pass effect, keywords, gastric acid, liver, those are the barriers that the drugs are going to pass. Drug, for example, let's make it 100 milligrams. The acid destroy 40 milligrams. They pass only 60 milligrams into the bloodstream. These 60 milligrams, they go then to the liver, and the liver, let's put it a number, destroy about 50%. So 30 milligrams will be available into the system in order to make effect. And what is that? It's called the bioavailability. The bioavailability, okay? Bioavailability. Please, if you have some questions, remember I was trying to prepare material, but definitely was a short time, so I just want to make main concepts, and slides are going to help for a little bit for them. Okay? All right, so let's keep going. We have, let me see. Okay, so for this, you need to remember that which medications or which routes are going to make, which routes are going to suffer from the first pass effect. So drugs that will not go into the GI tract. So that means the enteral medication. Enteral medication. So like tablets, like pills, like whatever is going to be solutions being taken by mouth, they are going to suffer through, they are going to pass through the first pass effect. First pass effect. Okay, sorry, I'm going to close the door. Just a moment. Okay, sorry for that. So, so that is about the, for example, the sublingual. You have nitroglycerin for angina, so the sublingual is going to be in the under the tongue, right? And that is not in contact with the gastric acid, so it's going to bypass the first pass effect. So it's going to be directly absorbed by the bloodstream, okay, at the level of the capillaries that are under the tongue, okay? All right, so let's keep going. Remember about kidney. Take notes about this, please. Kidney. Kidney, when it's failing, you cannot excrete the medication. Now, I'm going to put together things here. You never give potassium for kidney in kidney failure. You don't give potassium in kidney failure because the kidney potassium is being eliminated mainly by the kidney. If you give potassium a patient who has kidney failure, that is going to lead in hyperkalemia, arrhythmias, and death. Okay, cardiac arrest. The other substance or element that cannot give it to a patient who has kidney failure at all or kidney problems is magnesium. Magnesium. Magnesium is not going to, is mostly eliminated by the kidney. So if the kidney is not working, so what is going to do? Hypermagnesemia, so high levels of magnesium. High levels of magnesium. And high levels of magnesium is a depressor. So all the reflexes are going, our reflexes going down, slow down reflexes on the body, and you have LOC and you can enter into coma. Okay? So just remember, kidney failure, no potassium. Kidney failure, no magnesium. Okay? All right. So that is about that. Let's talk about, let's see, let's continue. All right, so let's talk about some drug side effects, and I want to talk about a little bit about medication errors. Talking about medication errors, for example, you need to know what are the 6 rights, right? All the rights of the administration of medication. You need to know some terminology, some abbreviations, like for example, PRN. PRN. What is PRN? PRN, very clear, is administered as needed. So that is what it is, PRN. PRN. Uh, Another thing we have, for example, medical errors. I want you to really go into the six rights and how to write down numbers, how to write down numbers. So you don't put, for example, you need to put 0.1, right? You don't put 0.10. You just want to put 1.0.1. So a zero at the beginning, before the dot, and no zeros at the end. So that is one of, of the recommendations that in order to prevent medical errors. Okay. All right. So what else? One thing. One of the most common medical errors is going to be when you are going to give verbally or verbally the prescription or orders by phone. So what you need to do is to repeat to the uh, repeat back all the orders to be sure that the orders are being transmitted verbally properly. Okay, so that is one of the things we need to remember. Talking about side effects, talking about the side effects, we have these allergic reactions, right? When you're talking about allergic reactions, you need to remember that one of the common is the signs and symptoms are rash, right? And these rash or hives are going to appear especially on the neck and face, right? Neck and face. Another thing that we need to remember about allergic reactions is, for example, the betadine. Betadine that contains iodine. Iodine. Betadine is what you use to clean skin for a procedure, and that is going to contain iodine. So people who are having allergies to shellfish, for example, so those can show some allergic reactions. So you need to ask if they are going to use this product, they are going to, you need to ask if there is allergic to fish or shellfish. Okay? All right. All right, so let's keep going. So talking about anesthetics, let me see. Anesthetics, okay? So the one of the important things or the concepts that I want you to remember is about this. When you give any type of anesthetic, especially when we are talking about general anesthesia, people who are in the OR, right? General anesthesia, they are going to receive anesthetics, whatever it could be, and they are going to receive some anticholinergics, right? So the reactions that can happen is called the malignant hyperthermia. Malignant hyperthermia. Malignant hyperthermia is high temperature. The patient starts to be shaky, sweating, and start to elevate the temperature very bad. Okay, so that is happening because of the anesthetic and or the anticholinergic. Because when somebody is going to go to surgery, they receive anesthetic and anticholinergic. Anticholinergic to relax muscles in order to make the surgeon perform better in the on the tissues. So you don't want a stiff patient. So that's why we give two medications. And these can lead in the at the time of the operation room, can happen almost immediately, can happen 1 hour or 2 hours or 3 hours after the anesthetic or and the anticholinergic are going to be administered. So this is called the malignant hyperthermia. So malignant hyperthermia, please pay attention to that. The antidote, that is what I want you to remember. The antidote is called the dantrolene. 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 I don't need to write it down because I know that you're familiar with that, right? All right. So dantrolene, D-A-N, trolene, dantrolene. What is the dantrolene? Dantrolene is the antidote for malignant hyperthermia. Dantrolene itself is a muscle relaxant, but they have this activity to reverse the effect of the malignant hyperthermia. If you have malignant hyperthermia, what can happen? It can happen actually seizures, coma, and can produce death. Okay, so that is about the anesthetics. That is the malignant hyperthermia. So if you see here, we have different the description: sudden increase of temperature, muscle contraction, tachypnea. So you remember this, every time that is going to increase the temperature 1 Celsius up, 1 Celsius, not Fahrenheit, 1 Celsius up, you're going to increase 10 times your pulse. Your pulse increase 10 times. So you have tachycardia. So for every Celsius go up, you increase your pulse 10 pulses per minute. Okay? So what is the antidote? Is the dantrolene. Dantrolene. All right. So now we already talked about that. Let's talk about the acid control agents. The acid control agents, and we are, please, I want you to really pay attention to this cartoon, because there's probably questions about this, and they are going to ask you, for example, if you tell me what I can ask you when I do this. Okay, so what is that? Antacids. So it's not antacids, antacids, right? These antacids are going to be, for example, the aluminum or hydroxide, the magnesium, right? The melox, all these guys. And what they are going to do? Listen, they are going to decrease the production of gastric acid, or is going to neutralize the gastric acid. So that is the key word, okay? So antacids, what they are doing is the neutralization. So you can see those arrows coming, finding each other. That is the neutralization. Neutralization. If I ask you which drugs are going to decrease the gastric acid, is the PPI and the anti-H2. So PPI and anti-H2 do not neutralize. PPI and anti-H2 decrease the gastric acid. So is that clear? Now we have here, just a moment. All right, is there some question or some difficulties to hear me or to listen? Please just raise your hand. I will pay attention to that as soon as possible. All right, so here we have the prostaglandins. Prostaglandins, what they are doing is increase the thickness of the mucus of the stomach. This mucus is the barrier in between the gastric acid in the lumen and the tissue of the stomach itself. Prostaglandin, okay? Prostaglandin. So that is mainly what I want just you to go through these acid control agents. And one of the things is that here we are going to talk about PUD. PUD is the peptic ulcer disease. What is the most common microbe that produce PUD? PUD is the Helicobacter pylori. Helicobacter pylori. Remember that, right? Helicobacter pylori. Then another thing I would like to remark here is some important side effects that you have to remember. For example, magnesium. The magnesium is going to produce side effect diarrhea. Diarrhea. Magnesium is antacid, right? Is a neutralized substance. And in excess, magnesium side effect produce diarrhea. Another antacid that is used is the hydroxide aluminum. The aluminum, what is the side effect of the aluminum is the constipation. 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 Okay? So then we have, I want you to remember some basic names, for example, anti-H2. Anti-H2. We have here anti-H2. The anti-H2 is, the names are the cimetidine, the ranitidine, and the famotidine. So these medications are going to be over the counter. PPI are going to be over the counter. There is some long-acting that is under prescription. But remember, PPI anti-acid mechanism of action is decrease the gastric acid. It's not going to neutralize. What it's doing, decreasing the production of chlorhydric acid. Chlorhydric acid. Okay. Okay, so that is about, all right, perfect. So let's keep going. Talking about anticholinergics. So in anticholinergics and cholinergic. So let's talk about cholinergic and anticholinergic. Cholinergic, remember the giant cat that can produce the contraction of the muscle, all right? So cholinergic, what is going to do is cholinergic, everything that is going to make it wet, right? For example, cholinergic. We are talking about cholinergic, no anticholinergic. Cholinergic. Cholinergic is going to increase the saliva, increase the urinary incontinence and defecation, right? So three of them. In addition to that, you need to remember that a cholinergic is going to decrease the heart rate. Cholinergic decrease the heart rate. Cholinergic decrease the heart rate. So if you know what are the actions of the cholinergic, you can tell me what are the actions of the anticholinergic. Anticholinergic, right? Anticholinergic. So the anticholinergic, if you have a lot of saliva, produce dry mouth. Anticholinergic. If you have in the cholinergic urinary incontinence, in the anticholinergic you will have urinary retention, right? If you have in the cholinergic defecation, so anticholinergic is going to inhibit the defecation. So that means the peristalsis. Peristalsis, what is peristalsis? Is muscle contraction, smooth muscle. Who is doing that? Acetylcholine, the cholinergic receptors. These cholinergic receptors are going to produce the contractility, increasing the motility and peristalsis of the intestine. So anticholinergic is doing the opposite, diminish all these peristalsis. And that is what you can see. Anticholinergic can be used as antidiarrheal, right? Antidiarrheal. Okay, so that is about, let me see, anticholinergic. Let me see another thing. All right, so we have the acetylcholine. The acetylcholine is is going to activate the cholinergic receptors. Acetylcholine stimulate the cholinergic receptors. The cholinergic receptors are divided in two. One is the nicotinic and the other one is the muscarinic. Muscarinic. So the muscarinic, mostly what is going to make effect is in the smooth muscle, the muscarinic, and the nicotinic is in the striate muscle. Striate muscle. If you give a little bit of cholinergic agent, mostly the muscarinic are more sensitive, more sensitive to this acetylcholine or cholinergic agent. If you increase the dose, that is going to cover the muscarinic and the nicotinic, and we don't want that. So that's why doses are very important. You don't want to give overdose of any of these medications. Okay, let me see what else we have. All right, so 23, 20, those are my notes, so don't think it's a number of questions. Okay, all right, so the anticholinergic, what they are going to do is the anticholinergic is going to do what? What is the mechanism of action? Anticholinergic, blocking the cholinergic receptors, right? It's going to block the cholinergic receptors. Okay. All right. So we have, in addition, we have the cholinergic effect. So cholinergic effect is everything that is wet. And please, cholinergic effect can decrease the heart rate. Can decrease the heart rate. Cholinergic, okay? Cholinergic. So anticholinergic is going to do the opposite. It's going to stimulate the, increase the number of heartbeats per minute. Okay, so we have another medication that is the hydrophonium, the hydrophonium that is a cholinergic agent, cholinergic. Hydrophonium is used for for diagnosis of myasthenia gravis. Myasthenia gravis. So I would like you to review what are the medications used for myasthenia gravis. Okay. Remark this is what we call the hydrophonium. The hydrophonium. Hydrophonium. Okay, so we have, for example, another anticholinergic we are going to talk about. So cholinergic is used for myasthenia gravis. The anticholinergic is using for decrease the motility. It means it can be used for treat diarrhea. They can be used for motion sickness. Motion sickness, open eyes, open ears, is the scopolamine. The scopolamine is going to be used for motion sickness. So if you go to a cruise, they give you a patch. They are going to use the for 3 days, right? And it's a transdermal patch. You don't need to cut it. You don't need to keep just to keep it for next time. So no, you need to use the whole dose. Okay, that is about cholinergic anticholinergic. All right, so here we have some other names that I really want you to remember. The scopolamine is what we just mentioned. Scopolamine, what you need to know is motion sickness. Motion sickness. We have the, and that is going to produce, for example, that is going to be used for motion sickness, so nauseous and vomiting too. So here we have the antihistaminic, the diphenhydramine, and that is going to use to prevent to motion sickness. So if you have motion sickness, the best is the scopolamine. Second is going to be antihistaminic, the antihistaminic. Okay. Another thing that can produce this, for example, another could be using for nauseous and vomiting is the droperidol, that is the antidopaminergic. Remember, everything that decreases the dopamine is going to lead into pseudo-Parkinsonism, extrapyramidal syndrome. Okay. All right. So one thing I want to tell you here is very important. I want just you to remember this is this, that when all the nauseous and vomiting are failing, okay, failing, all these guys failing, they're going to give you the dronabinol, that is the marinol, it's a derivative from the what? From the marijuana. Okay. All right. So here we have, and this is important for a patient who is in post-operative, especially. That is the serotonin blockers is the Sofran. Sofran is used for post-operative nauseous. Sofran is very common. So patient post-operative, Sofran. Okay, nauseous and vomiting. Here we have the Reglan. So Reglan and Sofran. Reglan can be used in post-operative too, and the Sofran too. So this is different mechanism of action, but they are very, very common to use in the post-operative patients. Okay, so let's talk about antifungals. And to talk about antifungals, what I want just you to, oh, just a moment. I want just to finish something. Okay, tell me, if you're going to use antiemetics, if you're going to use antiemetics, so that means for nauseous and vomiting, right? So if you're going to use antiemetic, when is the best time to use antiemetics? If you already know when the nauseous are going to start, the best action of any antiemetic or anti-nauseous are going to be administered before the nauseous start. Okay, it's going to be the best way to actually try to control the nauseous and vomiting. Okay. All right. So we have, in addition, we have the scopolamine. we already mentioned that is going to be for motion sickness. All right, so we got that. So let's continue. Talking about antifungals. What I want just you to remember, we have all these azoles. They can be systemic or superficial. One of the things I want you to remember is mostly the azoles. In general, antifungals, azoles is the most common use, one of the most common, are going to increase the anticoagulant effect. This is a must you need to remember. So, for example, ketoconazole, itraconazole, fluconazole, voriconazole, these guys, can, if somebody's taking Coumadin or warfarin, they are going to have actually increased the effect of the anticoagulant. And tell me one thing, the INR is going to increase or decrease? If that is going to increase the anticoagulant effect, the INR is going to be increased too. Okay, so we have the amphotericin, that is the mnemonic for amphotericin. B, that is for systemic diseases, systemic fungal infections. Systemic means that you have a system, that, for example, respiratory system or the urinary system. So those are invaded by fungus. So those are systemic. Mucus are considered systemic too, in the mouth or in the genital area. Fungal infections that can be considered general. So, but amphotericin is used for severe systemic fungal infections. And you have the mnemonic that we already mentioned in class, so please, I want you to review that. Okay? All right, so let's keep going. So let's go to a main topic here for the exam is the antilipemics. So there is many questions that can be here, many questions, many things that you need to remember. Of course, there's no space for all questions, but definitely I'm going to talk all what is relevant about antilipemics. Talking about antilipemics, just remember all the names that we have there, and I'm going to go straight to the point. Number one, in the previous one, we was talking that the antifungals, the azoles, can increase the effect of the warfarin. Here, in the antilipemics, the statin, all of them actually, but the statin is the one who has increased mostly the activity or the action of the anticoagulants. Which one is the most strong or potent antilipemic? Is the statin. And just remember this, please. I mentioned that. I know that I don't need to write it down. You need to remember the name, the HMGCO reductase inhibitor. Who is that? That is the statin. So you must know those names, both. The HMGCO inhibitor is the statin. Statin are the strongest antilipemic. So we have, what is the other name of statin? You already know. So what is the most potent antilipemics? You already know, the statin. At what time we are going to do a statin? At what time we are giving the statin to the patient? At night time. Where? Also, why? Because the cholesterol is being formed mostly at night. Cholesterol is being formed at night. So if you give statin in the morning, it's not going to be as effective if you give it at night. Okay, so I hope it's that clear. And all right. Okay, so what are the desired effects of the antilipemics? The desired effects of the antilipemics, you need to know the HDL, the LDL, the triglycerides, and the cholesterol. Okay, just remember that HDL is good if you increase the HDL. It is good if you decrease the LDL. It's good if you decrease the triglycerides. It's good if you decrease the cholesterol. So in general, the antilipemics, ones more than others in different, in any of these that I mentioned, are going to be basically have the same activity. all of them are going to increase the good and it's going to decrease the bad. Increase the good, increase the HDL. Decrease the bad, decrease the LDL, triglycerides, and the cholesterol. Okay, so you already know what is the good cholesterol, what is the bad cholesterol, and we have the HMG CO reductase inhibitor, that is the statin, so please don't forget that, is going to decrease the formation of basically of cholesterol. All right, so we got that. Let's keep going. Any questions, please? Yes. What time is it? I don't have time. Just a moment. Let's see. Okay. All right, so let's keep going. Oh, now is the turn to talk about the Parkinson. All right, so you already have all the Parkinson. You already know what is Parkinson disease. Is the imbalance of what? Imbalance of two neurotransmitters, right? So if you see here in the normal, we have the dopamine. Dopamine is up and the acetylcholine is down. Okay, so dopamine is an inhibitor, so it's going to tune your movement of your body. Okay, very subtle movements, very slow movements. Those are detailed movements are the dopamine. Meantime, the acetylcholine is mostly excitatory. Acetylcholine contraction. So you can tell that excess of acetylcholine produce some contractions of the muscle, right? So that is where it's coming from. Acetylcholine, remember, giant cat, right? Acetylcholine can produce this tremor and involuntary movements in patients with Parkinson. Acetylcholine. So what is normally happening is the dopamine is high and the acetylcholine is low. So just remember, when some is high, the other is low. When it's low, this is going to be high. So it's like a scale. Okay. So talking about Parkinson, I would like you to just think about, first of all, that these medications, especially the levodopa, so we have the selegiline, that is the MAO inhibitor, that is the neuroprotector, right, to protect the cells to be destroyed in order to keep producing dopamine. Then we have the dopamine, that is the apomorphine. Then we have the levodopa, and at the end we have the COMT. Okay, that is the entacapone. Entacapone is having less side effects than the rest. So if you cannot, it's not effective MAO, you're going to add dopamine. Dopamine is not enough, they are going to add levodopa. And levodopa, then we are adding the COMT. That is the entacapone. Okay, so these medications is going to take about 6 months to make effect. 6 months, especially the levodopa. This levodopa is going to take about 6 months, and the levodopa can not be taken with vitamin B6, pyridoxine, because the effectiveness of the levodopa will decrease. So we don't want to have this excess of vitamin B6 with levodopa. Okay, vitamin B6, the other name is the pyridoxine. Pyridoxine. Okay. Okay, so you already know we talk about the imbalance of the Parkinson, and let's keep going. All right, so if taking MAO inhibitors, don't take it with food that they have tyramine, yogurt, cheese, smoke, wines, red wines, okay? Because remember that can lead into hypertensive crisis or and death. MAO inhibitors. Okay. All right, so let's start talking about NSAIDs. And you already know, and this is a must, you must know this. Tylenol. Tylenol is not an NSAID, as you already know. It's not. Tylenol has properties as antipyretic and analgesic, but do not have anti-inflammatory effect. The maximum dose of acetaminophen is 3,000 milligrams. 3,000 milligrams. And let me see what I have here. No. And this excess of Tylenol that can produce, please, open eyes, open ears. If you give 3,000, more than 3,000 milligrams in a day, you can lead into liver necrosis, liver damage. So more than 3,000. And the antidote is going to be the acetylcysteine. Acetylcysteine. Acetylcysteine is the side effect of the antidote for the toxic levels of the Tylenol. Okay, Tylenol. All right, so let's keep going. All right, so let's talk about the antivirals. And talking about antivirals, the one who is really important is going to be the medication for HIV, is the sidobudin. Sidobudin, HIV, side effect, bone marrow suppression. Okay, so if you have bone marrow suppression, you have low white cells and or low platelets and or number of red blood cells. Because in the bone marrow, what produces the bone marrow? Three lines: white cells, red cells, and the platelets. So if they are being suppressed, this sidobudin can decrease the production of these elements. So one of the things, if you have low levels of red blood cells caused by the sidobudin anemia, if platelets, you're going to have thrombocytopenia, and for white cells, you have risk for infections. Okay. All right. So talking about the carbonic anhydrase inhibitor, that is the diuretics that is used. This is used for glaucoma. Carbonic anhydrase inhibitor is a diuretic. Diuretic is used for, the name is the acetozolamide, is using for open glaucoma. Okay, so here we have the cholinergic again. We was talking. Just remember the muscarinic, nicotinic. You can stop the slides when you want it. And you can see the muscarinic is what we want to have as effect, because it's going to affect smooth muscle, especially that we are looking for. And the nicotinic acid is going to be in the skeletal muscle that we don't need it and we don't want. And that happens when you have, you start with a small dose of cholinergic, is giving you muscarinic effect. But if you increase the dose, it's going to give you a muscarinic and nicotinic effect. Okay, so you can go there. And let's talk about diuretics. In diuretics is super important. The big guns and small guns. As big guns, number one, the loop diuretics. Number two is going to be the potassium sparing. Number three, the thiazides in that order. Okay. So what we need to remember about the loop diuretics is the loop diuretics can lead. First of all diuretics can lead in something important. Open eyes, open ears is the common side effect is the hypotension. Orthostatic hypotension, and all the considerations that you need to remember for that. You need to remember the names. Why? Okay, so let's start with the loop diuretics and we come back. So remember phytobum, right? Phytobum is furosemide, is the Lasix, ethacrynic acid, the torsemide, and bumetanide. So these guys, what they're going to do is to get rid of sodium and potassium. So if you get rid of sodium, potassium, what is the end is hyponatremia and hypokalemia. Now, loop diuretics is the big GAN, and the thiazides are going to be the small GAN. So they have the same characteristics of the loop diuretics, but is minor, is less severe. Let's talk about the potassium sparing diuretics. And the potassium, you must know the names: triamterene, amiloride, and spironolactone. So remember, we have TAS, right? So that is how you remember that. So what is the main thing that we must remember here is the potassium sparing, the potassium sparing going to retain potassium. So the risk is, but at the same time, is losing sodium. So the potassium sparing diuretics produce hyponatremia, but can lead into hyperkalemia. Meantime, the thiazides and the loops, they can produce hypokalemia, hyponatremia. But this, the TAS, the potassium, produce hyponatremia, similar as the previous, but produce hyperkalemia. Hyperkalemia. Okay, so that is about that. So just remember again, the acetozolamide is the carbonic anhydrase inhibitor that is going to be used for glaucoma. Glaucoma. Diuretics. At what time of the day you're going to give diuretics? We already know that is actually at night. You don't want to pee all day, right? All right. So one thing that we need to remember is about the gout, gout. Okay. When you're talking about gout, is because the loop diuretics and thiazides can decrease the excretion of uric acid. This uric acid are being deposited later in the bones, in the joints, producing what we call bouts. Bouts, right? Bouts of gout. Bout of gout. Okay. So, all right. So we have furosemide and thiazides in the long run can produce gout. So I have pain on my finger. I have pain on my toe, but I take in diuretics a lot. So that means that most likely is presence of uric acid, means gout. Okay. Another thing I want you to be very careful is, let me see here. Okay, it's not here. Is the thiazide combination what? Combination what? Diuretics. All right. So before that, I just want to finish. I'm sorry for that. Talking about the potassium sparing, the spironolactone. When you have ascites, fluid in the abdomen, because you have kidney problems, kidney disease, kidney um, dysfunction, or liver is being destroyed. So what happened is that the the one who we are going to use to get rid of the water of the abdomen is the potassium sparing diuretic. Why? Because if the liver is not working properly, this potassium sparing diuretic is less hepatotoxic than the rest of the diuretics. So that's why we are using this guy. Okay. So ascites caused by liver disease we are going to give spironolactone. Okay, so one more thing. If you have risk for hyperkalemia in potassium sparing diuretic, you need to be careful or suppress the salt substitutes, right? Salt substitutes. Salt substitutes are going to be the potassium, right? To give some taste to the food in order to make the patient eat more, right? Or eat without thinking that it's without taste. Okay. One thing, NCLEX again question: what substance or what part of the diet has high content of potassium? When you're going to give potassium, by the way, you're going to give potassium when you have the loop diuretics because they lose potassium, they lose sodium. So that's why you're going to take 1 glass of orange juice, banana or apricots. Don't forget the apricots, so please. Apricots. Someday it's coming that question. So apricots. Okay, please. Just remember that. All right. So in conclusion, if you have potassium sparing, avoid the use of salt substitute because salt substitute, what it is a lot of potassium. A lot of potassium. Okay, so let's keep going. All right, so let's see here. We are going to talk about the electrolyte imbalance. And talking about electrolyte imbalance, let's talk about first of all the dehydration. Dehydration. When you can be dehydrated. Okay, so let's make some example that I want you to remember. When you have alcohol, you have a binge of alcohol. Next day, you are going to have a headache, right? Mostly, you have big headache. Why is that? Because you pee a lot during the party or whatever. If you pee a lot, you are losing water. That means dehydration. So one of the symptoms, whatever is the cause of dehydration, is going to be headache. It's going to be headache. Got it? All right. It's going to be headache. All right. So that is electrolyte imbalance. We need to talk about the dehydration, and dehydration produce headache, right? Headache can produce hypotension because of the loss of fluid, right? Hypovolemic, so that is going to produce less cardiac output, less blood pressure, and dry mucus. You are dehydrated, right? So you are checking the mucus of the lips, for example, the tongue. You are going to find them that are very, 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 very dry. Okay, so just remember the main signs and symptoms of hypokalemia or hypernatremia are going to be weakness. The main signs and symptoms of hyponatremia and hypernatremia are going to be weakness. Weakness. So everybody is weak when you have electrolyte imbalance. The difference is that hypo or hyper, they're um, they are going to be mostly having cramps on the lower extremities. And hypo or hypernatremia is going to have cramps in the abdomen. Abdomen. The hyperkalemia, if the hyper or hypokalemia could be either way, can lead into arrhythmias, kalemia, potassium. And the natremia, that means hyponatremia, mostly have LOC. LOC. Okay. All right. So let's keep going. All right, so we have the laxative here. Talking about the laxative, I would like to I would like to remark this. Which one can be used for long term? Those are the metamucil. You can see that over the counter. Citrocel are going to be metamucil. I don't know if this is still over the counter, but metamucil, yes. And what is a powder? And you don't want to take the powder just dry like that. You need to have a lot of water, with a lot of water. And that bulk farming is used for long term. Long term. The other thing I want you to remember is we have the stimulants here, stimulants. That is the bisocodyl dulcolax. What they are doing is to irritate the mucus and produce the evacuation of the fecal material. Now, again, magnesium hydroxide or milk of magnesium, that is giving you the fastest and immediate relief. Fastest and immediate relief. Okay, so let's keep going. All right, so talking about narcotics. In narcotics, we have the morphine, that is the most common to mention in NCLEX on the quiz. And the morphine has some effects, right? So effect of depression of the respiratory system can lead into hypotension too, and constipation. Opioids are those can lead into those side effects. And just remember, the opioid antagonist is used the Narcan or the naltrexone. Naltrexone is NaL, naltrexone, here's at the bottom of the slide. They are going to be used as antidote for toxic levels of morphine. When do you have toxic level of morphine? When it's evident that the patient is having 12 or less respirations per minute. Okay. So now, we have patients who has the PCA. What is the PCA? PCA is a patient control analgesia. So one of the concerns of these guys, or these patients, sorry, is that they are going to become, they're afraid to become addictive to the morphine because They think that every time you are pressing that button, it's going to release the drug. And it's have a limit, it's under control. So you cannot have, actually, you're not going to become, and that is patient education. Patient education. Okay, so okay, so we have the opioid antidote. We already talked about that. We talk about the methadone. Methadone. What is the methadone? Methadone is an opioid and is going to be initially used as initial treatment for stop taking the it's treatment for addiction of opioid. Opioid, the we were saying the methadone is an opioid too, but it's less toxic. It's less addictive, less addictive. So that's why we start to give this naloxone to the patients in order to start his or her treatment. Okay. All right. So where I am. Okay. So that is opioids. All right. So just give me a second. We have another thing that we need to remember is the Vicodin. Vicodin. It's very common Vicodin. So please, I want you to really write down this 10 times. Remember Vicodin? Vicodin, what is Vicodin? Is the acetaminophen and the hydrocodone. Acetaminophen and hydrocodone. Acetaminophen and hydrocodone. Hydrocodone and opioid. Acetaminophen is analgesic and anti-fever. So it's going to be for fever, so decrease the fever. Antipyretic, antipyretic. So this Vicodin, that is the combination of acetaminophen and hydrocodone, there's Percocet, Percodan, we have other medications, and they are going to have, remember this mnemonic, Lucy, 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 Lucy. Side effects of the Vicodin, Percocet, and that is lightheadedness, L, U, urinary retention, C, constipation, and I, itching, itching. So mnemonic, Lucy. Okay, Lucy. All right. So let's keep going. All right, all right. All right, so let's start talking about the aspirin and the NSAIDs. Let's talk about the NSAIDs. Let me fix this stuff. Okay, let me finish this. All right, so we are getting there. All right, so talking about NSAIDs, I want just to review this. First of all, we have NSAIDs, we have three properties, right? Antipyretic, and analgesic, and anti-inflammatory. Acetaminophen is not an NSAID. Okay, it's not an NSAID. One thing is that the main side effects of NSAIDs are going to be the GI gastrointestinal upset and bleeding of the GI tract. Aspirin. Oh, sorry. And yes, it's going to be the aspirin. Okay, or in general, the NSAIDs. Sorry, and aspirin can do the same, but in general, all the NSAIDs can lead into GI upset and bleeding. Then we have when you are going to do pain management, you need to check the location of the pain, the severity of the pain, and the quality of the pain. What is the location? The location of where is the pain, the point of the body. What is the severity? Is 1 to 10 smiles. And the quality is going to be the somatic, could be somatic pain, visceral pain, neuropathic pain. So we already know, and I will invite you to review those concepts, okay? But it's very clear. So that before you give a pain medication, you need to check what is the pain, what is the severity, and what is the quality. Quality is, as I tell you, somatic, it could be neuropathic, it could be visceral. All right, so tell me one thing. If you have allergies to aspirin, what you are going to give? In that case, we will give acetaminophen, acetaminophen, acetaminophen. Okay, if you're allergic to that. Now, Tylenol, you know, this not having an anti-inflammatory effect, do not have anti-inflammatory effect. One thing that I really want you to remember is this. What happens when somebody is having NSAIDs and diuretics? NSAIDs and diuretics. So what happened, the interaction of NSAIDs and diuretics is that NSAIDs decrease the effect of the diuretic. So what you need to do is to increase the dose, or the doctor will increase the dose of diuretics. Okay. Another thing is the aspirin. Aspirin is the only one of all NSAIDs that can last 7 days as anti-platelet medication. So it's like, and what is the advantage of that? You need to take less dose, right? Less dose for this effect that is going to boost the or increase the activity of the warfarin. Warfarin. Okay. Seri, then we have all right. So garlic, for example, can increase the activity of warfarin, right? Remember garlic, GGGG, or the ginger, garlic, and ginseng, ginger, garlic, uh, what else? The other one is the, well, I will remember. And that is the increase, garlic especially is going to increase the activity of the warfarin. All right, so another thing that we need to just go over is the acetaminophen. It's not an NSAID, doesn't have anti-inflammatory effect. It's going to be toxic levels when you give Tylenol or acetaminophen more than 3,000 milligrams. So that can lead into hepatic necrosis. What is the antidote? We already talked about that. Is the acetylcysteine. Acetylcysteine. Okay. All right, so let's talk about a few more things. Yeah, we are almost at the end of the review. Let's talk about the alcoholism and um, drug use, right? Or addictions. Okay. All right, alcoholism. We need to remember that the anti-abuse effect. Anti-abuse effect. Okay. We don't have it here in this slide because I just prepared almost at the last minute. So we are going to talk about the alcoholism. Alcoholism, when there's a disulfiram, you're familiar with that, disulfiram, and anti-abuse effect. Anti-abuse effect. Anti-abuse effect is the same to say, to say, sorry, to say that is anti-abuse or anti-abuse effect. And for this, what I want just you to remember is that this anti-abuse effect, what is the effect of this? When you take some alcohol, whatever the source is coming from, this anti-abuse of this sulfiram effect are going to produce nausea and vomiting. Nausea and vomiting. That is the main. So it's very severe nausea and vomiting. So the patient will not like to take any of these alcohol in combination with this anti-abuse or the sulfiram. Another thing that we need to remember here is the Rufus. Rufus is the rape drug, right? And that is the flunitrazepam. Flunitrazepam. The flunitrazepam. Flunitrazepam. Okay. All right. So talking about the two more things, we have the fever few. Okay, the fever few. The feverfew is going to be a plant that is used for migraines. Then we have the isotretinoin. Isotretinoin is the vitamin A. Vitamin A. That is, you need to review, please, your eye pledge. Eye pledge. Eye pledge is a girl who has acne or comedones. They go to the doctor. They are going to be treated with vitamin A because the isotretinoin is a derivative of vitamin A, okay? And that can lead into fetal malformations. So they need to have two pregnancy tests negative. They need to have they need to pass 2 exams, 2 quizzes. They need to use 2 anticonceptive methods in order to receive this medication. That is the isotriene. Isotriene. Okay, and just about that. So if you have any, there's the few that I was talking about, the isotrione. So the few migraine, and please, this is for the future. Just remember this. You can take note or just copy, print the screen, and you will see that these numbers are very useful. All right, so that's all about for the review. I'm going to stop the recording, and we can talk. Just a moment. All right.